Bismillahirrahmanirrahim. Today we will discuss imaging characteristics of pulmonary tuberculosis. Here we have a schematic diagram where we can see right hilar lymphadenopathy, number 1, number 2 consolidation, number 3 pleural effusion, and number 4 miliary pattern of the disease. Lymphadenopathy, consolidation, and effusions can be seen in one case altogether, while they can be seen separately as well. So these features are typical in primary tuberculosis, while in post-primary tuberculosis or secondary tuberculosis, where reactivation of disease process takes place, we see consolidation in any portion of the or in any zone of the lung on either side. Usually it is prominent in apical segment of the lower lobe, as we see in primary tuberculosis, or in upper lobes on either side. We can also see nodules of variable sizes. They can be non-calcified or calcified. They can also show cavities as well. So we will call such nodules as cavitating nodules. We can also see irregular thick-walled cavity. We can see consolidation in combination with fibronodular densities, as is noted in right upper lobe. So due to underlying fibrotic component, there is loss of the lung volume. Because of this, we can see there is ipsilateral tracheal and mediastinal shift. We can see hilar pull on this side as well, and here we can see minor fissure is lifted toward this lesion. Usually lymphadenopathy and effusion is very less common in post-primary tuberculosis. So these are two classic imaging characteristics regarding pulmonary tuberculosis. Examples of primary tuberculosis. In this chest x-ray we can have one example, which is consolidation involving lower zone of the left lung, and in this x-ray we can see three findings. Two are very obvious. Number 1, right hilar lymphadenopathy. Number 2, consolidation in right parahilar region. And number 3, blunting of right CP angle, which represents tiny effusion. We can see left CP angle is sharp and clear. Now we proceed to isolated form of pleural effusion, and we see that effusion is more common in adults, less common in children, and it may be the only finding in primary disease. Here we have chest x-ray showing left-sided pleural effusion. In this x-ray we can see there is right-sided pleural effusion, and in this x-ray we have two findings, that is right-sided pleural effusion with right hilar lymphadenopathy. So pleural effusion may represent pulmonary tuberculosis. Here we have third pattern, which is miliary tuberculosis. We can see tiny millet-like nodules involving both lungs. Here we have both schematic diagram and chest x-ray. In this slide we can see x-ray chest and CT examination. We can see tiny nodules involving all zones of both lungs. This finding is obvious on CT chest. Another pattern of primary tuberculosis is lymphadenopathy. Lymphadenopathy is common, especially in children's and immunocompromised patients, that is, those who are HIV infected, and usually we see right-sided lymphadenopathy. Here we have few examples. In this slide we can see right paratracheal lymphadenopathy in chest X-ray, while on CT we can see pretracheal lymphadenopathy marked with red arrow. In this X-ray again there is prominent right paratracheal lymphadenopathy causing mild mass effect on adjacent right side of the mid portion of trachea. Here we can see right hilar lymphadenopathy in this X-ray. In this slide we can see right hilar lymphadenopathy with consolidation and tiny strip of right-sided effusion. So in this X-ray we see all three findings together. Here we can see few examples of post-primary tuberculosis. This is chest X-ray showing combination of cavitations and consolidation involving right upper and mid zone. We can see hilar are shifted toward the lesion with comparative reduction in the volume of right upper lobe. We can also see there is crowding of the ribs on this site. So typical appearance of post-primary tuberculosis. Here in this slide we can see X-ray chest PA view and lateral view, where we can see significant consolidations involving upper and mid zones of both lungs. Here in this slide we can see there is consolidation involving left upper and mid zone with red arrow showing cavity formation, and there is consolidation in right lower zone as well. Here in this slide we can see there is patchy consolidation with cavitations involving right parahilar region and left upper and mid zone, where there is associated left apical pleural thickening, and there is loss of lung volume because of underlying fibrotic component. And here we can also see there is blunting of the left CP angle. So all these features are suggestive of post-primary tuberculosis. Here is another example. We can see patchy airspace infiltrates with cavities predominantly involving right upper lobe, where we can see there is loss of lung volume, hilar pole, trachea shifted toward right side, while small cavities are noted on this side. And we can see there is hilar pole and upward shift of right minor fissure. We can also see there is blunting of right CP angle. Again, a typical example of post-primary tuberculosis, where there is consolidation, cavities, and fibrotic component leading to loss of lung volume and mediastinal shift. Here in this slide we have an example of post-primary tuberculosis, where we can see consolidation and irregular thick-walled cavity in it involving upper lobe. Here we have a few examples of irregular thick-walled cavities representing post-primary tuberculosis. In this slide we have CT examination of the chest. We can see irregular thick-walled cavity in right lung, scattered nodules and areas of tree in bud densities. Tree in bud densities are typical example of transbronchial spread of the disease. And in schematic diagram, here we can see these two green areas in left lung where disease process is seen involving bronchi and its branches. Here we have an example of multiple small variable sized nodules involving both lungs. So these are basically granulomas. Here in this slide we can see a nodule in left lung with a small cavity in it, and there is consolidation adjacent to it. Here in this X-ray we have a small nodule, or we can say it is a solitary pulmonary nodule with tiny high density focus in it. When we did CT, we can see a peripherally subpleural nodule in left lung where we can see a tiny high density areas suggesting calcification in its parenchyma, favoring calcified granulomas. This is an example of patchy consolidation involving upper and mid zones of the both lung. Patchy pattern on X-ray may represent endobronchial spread of the disease. However, it is better to see this pattern in the shape of tree and bud densities on CT. So here we have CT chest, where we can see a regular thick walled cavity in the left lung surrounded by consolidation, while tree and bud densities are also appreciated in interior portion of the left lung. Few nodules are noted in right lung. Similarly, we have two CT images which shows tree and bud densities in right lung favoring transbronchial spread of the disease. Here we have an example of bronchial stenosis, which means that tuberculosis involving any of the major or minor bronchus leading to fibrosis and stenosis, which is noted in this slide, in where we can see there is narrowing of proximal portion of the left main bronchus, which can be noted in axial CT image, and here stent is placed in this portion and its caliber is again maintained, we can see on X-ray. Here we have a couple of slides showing improvement after treatment. We can see there is large area of consolidation involving upper and mid zone of the right lung, and on left side we can see it is grossly reduced with treatment. Here is another example. Red arrow shows small opacity in subpleural area of left upper zone, and in adjacent picture you can see it is almost completely resolved with proper treatment. And here we have a post-primary involvement of the pleura. Pleural effusion may occur in the post-primary disease, but it is less common. Empyema is more likely in the post-primary disease, while air fluid levels suggests bronchopleural fistula. Here we have a slide showing pleural thickening in right lung, and this can be confirmed with the help of MRI of the chest, where we can see pleural thickening. Here we have an example of bronchopleural fistula, where there is significant reduction in the volume of left lung with ipsilateral mediastinal shift, and we can see air fluid levels favoring bronchopleural fistula. Here we finish our presentation. Thank you so much.